Today I'm going to be doing a mass removal on a dog. I'm Dr. Meggs, and this is Everyday Vet.
Can I also have you grab me a 4-aught suture?
I'm feeling around the base of the mass to make sure that I'm aware of where the borders are. Because this mass does extend deeper. You can see that surface area on top, that pink spot, but it does actually go deeper in the underlying tissue. So I'm going to make sure that I remove those deeper tissues as well. Since the base of the mass doesn't directly line up with the visible portion on top, I'm just going to make some small cuts to mark out those margins, and I'm going to be feeling the base of the mass as I go. Once I've got my little incisions marked out to indicate where my overall skin incision can be, I can now go ahead and connect those smaller incisions in order to make my overall surface skin incision. I'm making it in an elliptical shape with the top part of it being more pointy as well as the bottom part. This allows me to get a better closing of the skin at the end of the surgery without resulting in as much tissue bunching. I don't want to end up having a big glob of skin at the top and bottom of the incision when I close it up. So by making that elliptical type shape, it allows for a better closing of that area at the end of the surgery. I'm just going to go ahead and I'm going to clear off some of that charged tissue that was left over by the laser. The laser cauterizes as it cuts, but it also leaves some of that charged tissue behind. Part of my problem is that the area is not wide enough, so I'm going to go ahead and cut away some of that extra drape tissue. That way it's not sliding into my surgical site as much, and then I can apply those extra clamps to hold it down in place. And I need to move that one too, because that one was also slipping up into my incision site.
Much better.
Now that I got my drape sorted out, I can continue with my incision. So that first cut was just on the very surface of it, and now I'm going to need to extend down deeper through the skin layers. So I'm applying tension on both sides of the incision there, that way I can spread out the skin and get a deeper cut. It also helps me gauge how deeply I'm cutting with each pass of the laser. I am making a bit of a sweeping type motion with the laser, so I'm going back and forth over the same area of tissue, and that's allowing me to get a deeper and deeper cut. If I turned up the setting on the laser, each pass of the laser would give me a deeper cut, but then I would have less control over how deeply I was going. So by making that sweeping motion, I have much more pinpoint accuracy with how deep that cut actually ends up being. Oh, and I'm going to stop because I ran into a little bleeding vessel there.
Found a bleeder. No, not too bad, just easy.
I'm opening up my suture in order to get it prepared in case I need to suture close the vessel. Typically what I'll do is I'll apply a hemostat clamp onto the vessel first in order to close it off, stop the bleeding, and see if I can get a clot to form. But I do like to have that suture ready to go and my needle drivers there just in case I need it. I'm going to go ahead and I'm going to clamp off that little vessel that I cut through. I'm wiping away the blood because I need to see if there's active bleeding or if it's just residual blood from when I had initially cut through the vessel. And I'm not seeing any extra, but I'm still going to go ahead and I'm going to clean it up some more. Looking pretty good. I'm going to go ahead and I'm going to leave that clamp on there with the idea that given more time, it will get that bleeding to stop and it will close off that vessel for me. I'm using the forceps right now in my left hand to grasp that skin because by grasping it right on the edge, I can lift it up and I can see which tissues are still connected and I can use the laser to cut straight through those. I can grasp the skin essentially as tightly as I want to because I'm staying on the side of the incision that is not going to be remaining. So all of that tissue right now that I've got in those forceps is tissue that will be removed with the mass. I would not want to do this on the other side of the incision because I could be causing some bruising or some actual trauma to the skin layer, but I don't have to worry about that because this skin is going to be removed anyways. And this can dramatically aid in my visibility of what I'm doing, applies that tension there so I can get a really good look at how I'm dissecting. But again, this dog has some really thick skin, so it's taking me quite a few passes in order to get deep enough in there. And you'll notice there is a little bit of bleeding that's occurring through here as I cut. That's normal. None of the vessels are continuously bleeding or spraying out blood, so there's nothing at this point that I need to actually clamp off or suture closed because it's just a very slow ooze. So it's just a matter of determining, at what point it's bleeding too much and you have to clamp down. And that first one, he wouldn't have bled out if I left it not clamped by any means. He would have been fine, but I could minimize the bleeding there because it was clearly a pinpoint section of a bleeding vessel. Now I'm just continuing up around that side of the mass. And I cut into another vessel. So you could see with that one that the blood immediately bubbled out and there's still a steady stream. So I am going to want to stop the blood flow for this one. Otherwise it's just going to keep bleeding, it's going to obscure my vision, and it's going to contribute to further blood loss for this patient. So that is the level at which we do want to do something about, as opposed to the other side where it was just a small little ooze that had no real impact. I'm having a harder time finding exactly where this one is coming from.
Goodness, no.
I'm going to use one clamp to lift the tissue up so that way I can see it better, and then I'm going to use a second hemostat to clamp directly over the vessel to stop the blood loss. I like to use this type of scissor because I can use the tip of it to spread out the tissue and see what I'm cutting through. It's a really convenient way to dissect up underneath the mass. I'm just going to spread those tissues out, see that there's no vessel in there, and make my cut. I'm going to continue to do this in order to work my way around the mass in this area.
Made a mess.
I'm going to need to cut through that little vessel that's going to the mass, because as long as it's still attached, I'm not going to be able to remove the growth. So I need to dissect down deeper to get to the level of that vessel. I'm just making those cuts there because I know that the vessel is roughly in this area. And I got a little bit of blood there as I did cut through the vessel. That's okay, that's what I was trying to do anyways, but since it's bleeding, I'm going to go ahead and put a clamp on it. Cutting through the vessel allowed me to free it up by dissecting it into the left and right sides, and now that I have it separated out, I can continue to dissect right between the middle of it to get down to the base of the mass. I'm going to keep dissecting now that I got those clamped off. And we've got some more bleeding, so I'm just going to go ahead and I'm going to reposition that hemostat there. Now that I've made my cut deeper, I can definitely see where that vessel is coming through a lot easier, so it's improved my visibility. Now that I've got that clamped off, I'm going to need to keep dissecting. When removing the mass, you have to cut deep enough to get to the base of the mass, but once you're deep enough, you then need to start cutting down underneath it. That way you can scoop the whole thing out. So as you can see, more so on the top there, since I am deeper with it, I'm starting to angle down underneath that mass. That way I can remove the whole thing. There's a lot more tissue involved than it looks like there is just from the surface. So all of that tissue that I've got coming out is very thickened and it's going deeper. So if you just look at the visible portion of the mass on the skin, there are a lot of times that you'll actually miss the full scope of the mass. This one looks like, oh, it's just a little small mass on the surface. It'll be quick and easy to remove, but if that were the case, you're actually missing a lot of what's going on down deeper underneath the skin layers. Gonna get another clamp on this one. I'm getting quite the collection of hemostats in my surgical field, so I'm going to need to start placing some sutures soon. That way I can get these hemostats out of there.
Oops. I lost a clamp. Do you need another one?
No, I'm good. Do not need that one anymore.
My goal wasn't to throw it on the floor at you, though.
And that vessel's not bleeding since the clamp fell off, so no need to put a new one on there at this point. I'm gonna just keep on dissecting. When I start my initial dissection of the mass, I like to stay fairly symmetric between the sides in order to keep everything kind of evened out. But once I get to this point, I then pick one side and I dissect down underneath the mass and work to the other side. So my initial incision to get deep enough, I try to stay fairly even between the sides, but once I'm deep enough and just trying to get underneath it and bridge the two sides, then I pick one aspect and kind of stick with it. So this one I'm staying mostly in the top of that mass, simply because it's ideal positioning for me. I can pull it back and I can make that cut underneath it. With some continued dissection, that vessel is back to bleeding again, so I'm going to be putting a clamp on it and then I'll be suturing it closed. Since I'm getting towards the final stages of the mass removal with this, it's easier for me to apply the stitch right when I'm applying the clamp. I don't want to keep accumulating clamps because they're going to be getting in the way as I'm trying to dissect underneath the mass. The only step left is for me to then dissect underneath the mass and remove it out. So if I keep a bunch of hemostats collected through this, they're just going to get in the way. Right, and the bleeding stopped, so we're good to keep going with the laser. Still pretty attached down there at the bottom of the incision, so I'm just cutting that a little bit deeper before I continue. And of course found another little bleeding vessel. That was not too bad though. Sometimes you can get them to cauterize enough with the laser, so that's what I'm trying to do here. And it looks like it worked. And I'm going to continue to dissect down under. So again, I'm doing that blunt dissection and then that sharp dissection. So blunt is I'm using the tips of the scissors to spread out that tissue, and sharp is I'm using the blades to actually cut the tissue. And I can actually use this wet gauze as a backstop, so I can stuff it right up underneath the mass, because the CO2 laser that I'm using will not cut through the wet gauze, so I can stick it in there and I can use it as a backdrop and I can cut right through that tissue. Use it up to clean up that little base where I just made that cut. Everything's looking good, so we're going to keep on going. Getting close, just have a little bit more tissue to cut through. Gonna get some of those extra hemostats out of my way. We can get this mass out of there.
Oops.
I hit myself in the head. Mine's the sixes. Dump it out on the back. Try to put the other one upside down. That works so great.
All right, we're in the home stretch. Just got a little bit of tissue left. Just gonna laser through that last bit of tissue that's holding this mass in, and then we'll get it out of there. Just got that tiny bit of tissue. Just gotta make that one final cut. All right, the mass is gone.
They didn't want to send it out.
Sometimes we'll send it out to the pathologist to analyze, but the owners didn't want to.
This.
Alright, I'm just going to pull those skin edges together so I can plan how I'm going to suture it closed. I'm experiencing a little bit of tension there.
Can I have 2 aught, please? Thank you.
The key thing when closing the incision is that I want to make sure that I get rid of any tension, as that can cause discomfort and it can cause the incision to open up as well. So I'm using a little bit of a bigger suture for this than I did when I was suturing close those vessels. So with this one, I'm starting a little bit closer to that edge on the top there, just to make sure I get that good line up with the closure. Just checking it, making sure it lines up right.
Attempting to get my first tacking sutures to make it line up how I want to, so I have less to change to get to the next one. Makes life easier. This on the other side of that though.
I'm just gonna get this pulled tight and make sure that this one's gonna work right. If you look at the top of the incision there, it's nice and pointy. Those skin edges are lining up nice and symmetrically. They're at the same level as each other. There's no major gapping between them, and there's no bunching of the tissue. So that's the alignment that I'm looking for at this stage.
Yeah, definitely. And it lines it up right. So I'll have a few layers, but if I do a couple of tacking ones first, it gets it like at least in the right ballpark. Make it look nicer. And I can tack them down in the middle so it like gets rid of all that like empty dead space in there. So less fluid accumulation after.
This next stitch I'm doing towards the bottom of the incision, that way I can get that end nice and lined up as well. I'm just tacking it right in the middle to get that nice and closed. By taking a bite with the suture in the middle of the incision like that, I'm helping to get rid of some of the tension because I'm anchoring it in the middle. It's also helping to suture that actual tissue layer down to the underlying layer, so that way we don't have an empty space left behind. And I'm going to do another one right in the middle there. This layer of stitching that I'm doing right now is intended to bring those skin edges closer and help get everything lined up, but it's also the layer that's removing that tension from the area. So since these are holding all of that tension, this is the stitch that needs to be thicker and stronger. But since this is taking that tension away, the layer that I do on top of it does not need to be as extensive as this one. The next layer will simply be to help close it up, reduce any space, and again get those skin edges closer, but it won't be experiencing any tension because I've already alleviated it with the layer that I'm doing right now. So because this one's taking care of the tension, my next stitch layer does not have to be as strong of a stitch material, so I'm going to go ahead and I'm going to use a smaller suture size for the layer that I'm doing on top of this. If I stick with that thick suture that I was just using, I'll end up with a huge bulky mess of suture material, so it's better to use a smaller one on that next layer, that way I'm not getting so much bulk from it. And as you can see, the skin edges are already much closer to each other than they were in the beginning. So since everything's lining up, I'm no longer going to be having to manipulate where the skin is resting against the next layer. It's already lined up. So this one I'm just doing to kind of keep everything closed. So instead of doing the separated individual stitches like I did on the last layer, this one's going to be a continuous line of suture. Another thing that's important to know with just planning for wound healing in general is the length of the defect of the skin does not impact how fast it heals. So what that means in this aspect is that the distance from the top of the incision to the bottom of the incision will not alter how fast it heals. But what does change how fast something heals is how far the skin edges are away from each other. So in this view, that's going to be how far the left side of the incision is from the right side of the incision. So it doesn't matter the length of the incision, but it does matter how close I'm able to get those skin edges together. So I'm going to just keep on adding layers of stitching until I get it as closely together as I can. That way we can just speed up that healing process. As I'm getting towards the end of this layer of closure, I can see that my skin edges are actually lining up much more tightly than I had initially anticipated that they would be. There's no further gapping between the skin layers, and there's no puckering of the skin. This is actually the alignment that I would like to maintain by the end of the surgery. So because I have accomplished that with this layer of closure, what I'm going to need my skin closure to do is to help maintain this alignment as well as accommodate for any swelling of the tissues that occurs as the patient is healing. So since those are my ending goals going into this skin layer of closure, my best option is going to be to do a surface layer. So I'll be putting stitches directly on the surface of the skin as opposed to another buried layer, because that will help me accomplish that goal of maintaining the skin alignment as well as accommodating for that swelling. Another thing that I'm noticing as I'm suturing up this incision here is that his skin is getting kind of a salmon pink color on either side of the incision, and that just to me indicates that he's getting a little bit of inflammation building up. And inflammation along the incision site is very common when we're doing mass removals because the masses tend to have more vessels associated, and when you cut through it, you cause more tissue reaction and just an increased swelling. I'm also having to manipulate the tissues a lot in order to dissect deep enough. So swelling is common, but it's also an area that we have to be aware of during recovery, because once the surgery is over, the tissues will likely continue to swell. So I want to make sure that when I'm doing his skin stitches, I'm taking into account that he will likely encounter more swelling as he continues to heal. So with this cruciate type stitch, the X shape of the stitch is actually what helps to alleviate that tension across the incision. And we make this type of stitch by starting on the right side of the incision. And we're going to pass the needle through that side of the skin, coming up through the middle of it then, so I can move over to the left side. And I'm going to go straight across on the left side and come out through there with it. I'm not going to tie my knot, and I'm not going to cut my suture just yet.
Yeah, I mean, he's even bleeding like around the space where I'm putting the stitches.
Now I'm just moving down ever so slightly on the right side and coming down beneath that initial one. Again, up through the middle, and then I'm going to go straight across to the left side. So now my two suture edges are that bottom left corner and then the top right corner. So by tying those together, I'm making an overall X-shaped pattern on top of the skin. Here we can really see the temptation to put in skin staples, and there are a lot of surgeons that would have chosen to do skin staples here. It's definitely taking me much longer to put in these stitches than it would have if I had just stapled down the incision line, but the reason I prefer the stitches is because for me they're easier in the long run. Yes, this part takes a little bit more time, but when I go to remove them, it will be much easier. All I have to do to remove a stitch is use some suture scissors, cut the stitch free, and pull it out. Whereas removing skin staples is very similar to how you would remove a paper staple. It's the tool with the metal prongs that you have to squish down underneath the staple, clamp it closed to press down on the staple and release the little prongs on the side and pull it out. And for some patients, this can be an uncomfortable process, and it does take more time, at least for me, to remove the staples in comparison to the stitch. So I would rather take the extra time to put the stitches in while the patient is anesthetized, so that way the removal process when the patient is awake is less traumatic and quicker. But again, it's going to be a surgeon preference.
The nice thing about the crochets is I can slide them around and reposition where the knot is too. It's like I just slid this one that way because the tags were getting stuck in this suture. So by sliding it, the tags are now over here, so they're not in my way. That definitely impacts it too. Let me not go this way. But I am gonna put a simple interrupted here because there's too much gap between them. I mean, it'd be fine, but I'd rather have the extra one in there. But that's a nice thing. Like, you can put your crew sheets in and then see how they look, and then if you need to fill them in, put interrupted.
So I had a little bit too much space between my top two cruciates there, so in order to bridge that gap, I'm just placing a simple interrupted suture. So with simple interrupted, all you do is you pass the suture from the right side over to the left and then tie it on top. It's not a continuous line, it's no X-shaped pattern on top, it's just a simple stitch placed right between those two cruciates in order to bridge that gap.
All done. And then I'll clean it up with the gauze.
And that concludes the surgery. Thanks for watching. If you like this video and want to see more like it, be sure to subscribe to the channel. And don't forget to turn on that bell icon to be notified when the latest videos come out. If you have any questions, be sure to leave them for me in the comment section below. I'm Dr. Meggs, and this is Everyday Vet.